Hello and good morning, everyone. Welcome to this week's Inside APSAD webinar. Before we begin, I'd like to acknowledge the traditional owners of the land. So here at Insight, we're based in Brisbane, so in Miagin, the lands of the Turrbal and the Yagara nations. Like to also acknowledge the traditional owners of the lands on which we're all meeting this morning and coming into this webinar from, to pay respects to elders past, present, and emerging, and also extend that welcome to any First Nations people who are going to be joining us in this session this morning. So great to have you along. And as you've probably joined one of our webinars before, or if you're here for the first time, we always have the opportunity of hearing from wonderful and learned people in the field of alcohol and other drug work, and today is no exception. I have the privilege of welcoming Professor Leanne Hides, who is a good friend to our service here and has presented with us previously, and also is a great researcher and advocate in this field. Leanne comes to us today in her role currently as the Lives of Well Chair in Alcohol and Other Drug Mental Health work at the University of Queensland. Leanne's also the Deputy Director of the National Centre of Youth for Youth Substance Use Research, and is also a clinical psychologist with over 25 years experience. So topic today, and Leanne will tell you more about that, is around the use of routine outcome measures, something that's increasingly, or really has always been a kind of an active conversation in the AOD world since I've been working in it, but is something I think that's something that more and more services are moving towards. So it'll be great to get some up-to-date coverage of that. So Leanne, I'll hand over to you. And just to, as we're doing that and Leanne's getting herself set up, I'll just remind everyone, please pop your questions in the chat. We'll collate and curate those and hopefully have the opportunity to get as many of those across to Leanne for her comment and feedback towards the end of the session. So thank you very much, Leanne.
Thanks, James. Thanks for such a lovely welcome, and apologies for missing my cue to bring up your acknowledgement of country slide. Okay, so as James mentioned today, I'm going to be talking about the benefits of routine outcome measures and feedback in the drug and alcohol sector, using a case example, which is obviously going to be Lives of Well, who I've been working with for quite a long time in this area. So also just wanted to do my acknowledgement of country. The University of Queensland acknowledges the traditional owners and their custodianship of the lands of which we're all meeting on today. Pay our respects to their ancestors and their descendants who continue cultural and spiritual connections to country. We recognise their valuable contributions to Australia and the global society. I think I'm preaching a little bit to the converted with the audience that is normally attracted to these Insights webinars. We've all quite concerned about the high rates of substance use in Australia and worldwide. We know that in Australia, the KPMG report that came out in 2022 showed that it was costing Australia, alcohol and other drug use was costing Australia 80 billion in 2021. And there's global burden of disease data clearly showing that it's a very big risk factor for death and disability across all age groups. And so from our perspective, it's critical that we try and deliver cost-effective evidence-based treatment to try and reduce this burden and huge cost of alcohol and drug use worldwide. In an Australian context, we're very lucky to have access to free treatment, but I guess we're seeing an increasing demand for treatment and we're not getting the resourcing needed to cover that. So you can see there that around 140,000 clients received treatment in 2020-2021. That's gone up about 20% since 2014-15. And the modelling work that Alison Ritter did a couple of years ago shows that the treatment needs of between 44 and 73% of people with the current disorder are simply not being met by the current services available. And I guess our concern with this situation we have in Australia, where the demand for treatment greatly outweighs the resources available, is that some people just aren't getting into treatment. And when they do get into treatment, the front end of service is so busy with the sheer volume of people seeking help that it can kind of start resulting in services just trying to in this attempt to try and get clients into treatment, that perhaps the quality of treatment goes down just through the sheer quantity of people coming through. So, and just in this climate where there's this really busy front end and there's not much time to do treatment, it can result in people not getting access to evidence-based care. And we also know that even within treatment services that do deliver evidence-based treatment like Lives Live Well, there's still a 10 to 25 year delay between when the evidence is collected and when it's put into practice. So these are the big issues that we've been trying to get addressed together with Lives Live Well since 2017. And to me, what I think we need to do is shift our focus towards a more value-based healthcare model. And that's where we shift the focus away from the volume and the number of clients seen towards client outcomes that are valuable to the client themselves. And I think it's consistent with the philosophy of the sector itself. It's just that we've just got this juxtaposition where we've got huge demand and not enough treatment resources available. So we've got to try and figure out what we can do to try and even that out. The other thing is clearly our funding models support sheer volume. So we need to try and move the focus to quality and treatment outcomes. And I guess routine outcome measures are really at the centre of value-based healthcare. And what we're trying to do with these outcome measures is identify what outcomes matter to clients and work with services to implement a core set of outcome measures to assess, monitor, and provide feedback on treatment, not only just outcomes, but progress as well. And ultimately then, if we can try and get these routine outcome measures happening regularly within services, we can then use that data to learn what's working for which clients in what settings to improve the efficiency, outcomes, and cost effectiveness of treatment overall. And we know from studies done overseas that these value-based healthcare models have been shown to optimise service delivery in cancer, cardiovascular disease, and mental health services. So they can actually achieve our ultimate goal of increasing access to evidence-based care. So that's what we're trying to do. So to try and achieve this shift in drug and alcohol policy, practice, and funding, what we've been trying to do with working with Lives Live Well is just trying to develop this value-based healthcare model. So today I'm just going to be talking about the work we've been doing together to implement routine outcome measures and feedback within their services to try and sort of focus and move this to the focus towards these value-based healthcare models. The first thing we did was work with Lives Live Well to identify what some of the routine outcome measures might be, both from the client and the staff perspective. They were already doing some outcome measure monitoring when we started working with them, but mainly paper and pencil, and there was no regularity to it. So what we did is we worked together to come up with this list of core measures. So we've got for drug and alcohol use, the Australian Treatment Outcome Profile, which measures the frequency of alcohol and drug use in the past month, as well as typical quantity of use within that time frame. It also has a range of important quality of life indicators, which are very important to clients themselves, as well as Lives Live Well staff. We also included the Assist, which gives us a measure of drug and alcohol use and related problems in the past 3 months. From the mental health perspective, we included the Patient Health Questionnaire 9, which gives us a measure of the severity of depressive symptoms in the past 2 weeks, including suicidal ideation. Anxiety was measured using the Generalised Anxiety Disorder measure, which is 7 items, which gives us a varied measure of anxiety in the past 2 weeks. We also had a PTSD screen in there, as well as a psychosis screen in the terms of just a question about if they've ever had a diagnosis of psychosis. So what we did is when we implemented these measures, we implemented them such that they were done at service entry and then repeated at 1 and 3 months follow-up. So the A top is only, the Assist, is only done at baseline in 3 months because it's a 3-month measure, but all the rest of them are done at every time point, except for the PTSD screen and psychosis screen that is done at service entry. one of the first things we wanted to do, because we were delivering these measures to clients to complete online in a self-report format. So we really wanted to look at to make sure they're reliable and valid when they're delivered that way. And I won't go into this lot of detail, but it shows that there were good to excellent levels of reliability for all drugs for the ATOP and the assist, except for some moderate reliable for tobacco on the assist and other opiates on the ATOP. So what we took from that was that when these measures that were traditionally delivered as interviews were valid and reliable when they were delivered online directly to clients to be self-completed. Some of the other work we did was working with counsellors and other staff at Lives of Well to really identify what some of the barriers might be to implementing routine outcome measures, or the challenges as well. And there were quite a few. So counsellors just felt they were so overwhelmed with case management and the front end of the service, there wasn't much time to deliver outcome measures or feedback to clients. They had concerns that they might be a bit off-putting for clients. They might not be able to complete them themselves due to some literacy issues. It'll make them disengage from treatment, that they don't want to complete them because they want to come in and tell their story. They want to have a full assessment first before they start completing these measures. They won't be able to access them because they won't have emails or mobile phones. And then there was a range of organisational and system issues that we had to work really hard to overcome. So taking it from paper and pencil to online delivery, sort of just kind of trying to get the policies and procedures and training together to sort of support the implementation of outcome measures, and then just the system itself and the funding models and also the requirements for different funding schemes towards different types of outcomes they wanted to measure. So there was a lot of structural barriers, but also some barriers within the service that we needed to address. What we ended up developing, we used Qualtrics, which is an online survey software. So that sent the routine outcome measures to the clients at service entry, and then they'll repeat it at 1 and 3 months follow-up. As soon as the client completes those measures, the Lives of Well clinician receives the Qualtrics feedback directly via email. And we also developed a system where Lives of Well's client relationship management was sending these outcome measures to clients at baseline 1 and 3 months as well. So that's how we kind of got around some of the structural barriers. This was implemented back in November 2020 across 167 Lives of Well programs and approximately 426 staff across Queensland and New South Wales. And so this was just a system where people would come in, they'd be enrolled in the service, and then they'd be sent the baseline measure, and then we'd ask the counsellors to provide them with feedback on those outcome measures. We built in a system such that if the client had difficulties or completing the measures or was unsure or uncertain about it, they could seek help and so get support from a counsellor to do that, either via phone or face-to-face. We had reminders built in, automatically scheduled, and Lives of Well developed some training packages as well to get staff up to date with what we were doing. This is what the feedback originally looked like. It's generated by Qualtrics itself. So as you can see, it gives, this goes straight to the clinician. So it gives them an idea of what the client is saying they're using, how frequently they're using, the typical quantity they're using, and then also some feedback on anxiety and depression as well, and how to interpret those scores with the client. So this is some data from 17,274 clients that was collected between May 2021 and November 2022. And so I'm just showing it's just to give you a sense of just what happened when we implemented this program. We obviously, back in November 2020, there was a lot of glitches and little things we had to fix. So we started from May 2021 to really look at the data once we'd got it up and functional and working really well. So as you can see, across 135 services, at baseline, about 70% of clients completed that measure, which we were amazed by. We thought it'd be 50% at best. And that it didn't really differ much between residential and outpatient services. It's obviously a bit higher in residential because they're right there and at the service themselves, but still, you know, 84% of clients in residential services and 69% of clients in outpatient services were pretty fantastic results. When we look at the 1 month and 3 month follow-up, so that some of them are not in the service anymore at this point, you'll see around 40% of clients are completing the 1 month follow-up, and around 21 to 25% of clients are completing the 3 month follow-up. And there's really not much difference there between those completion rates in outpatient and residential services, which was good to see. This is just showing it graphically, such that you can see that at baseline, 70% of all services were completing that measure. It was a little bit higher in the resis, but over time you can see that at 1 month and 3 months is pretty consistent across those different service types. When we looked at active versus inactive clients, and that was defined as having any contact with the service in the month previous to or currently being active in treatment with the service, we can see that active clients are definitely, which are the purple people, are definitely more likely, 2 to 3 times more likely to complete an outcome measure, regardless of whether in residential or outpatient settings. And that's particularly the case at 3 months follow-up. So obviously, if they're still active clients, they're probably more willing and engaged to complete the outcome measures, but we were still sending them to them even if they were inactive, because we were hoping that it was a way for them to keep monitoring and keep track of their progress. And also we've found over time that it's actually a really great way to re-engage clients back in treatment who perhaps would discharge and were doing well, but then had a few lapses and struggling a bit, or people that maybe just stopped coming and then completed some measures and thought maybe we should come back in. So it's been quite good for that. But obviously we need to do a bit of work to try and increase the uptake in those inactive clients. So these are the key learnings we had at this point. Clients will complete outcome measures at service entry, and that 70% of those were completed at baseline, and between about 40% around 1 month and about 25% at 3 months. And I guess we found no differences between those outpatient residential services, and that asking people to complete outcome measures at service entry certainly was not off-putting for them. We found that by bringing these in, we had no decrease in the number of clients who were inquiring for treatment who were eventually enrolled. It was pretty consistent across the whole time frame, around about 56%. Around 45% of people who completed the outcome measures out and did enroll in treatment, and about 35% of them got at least 1 treatment session. And that wasn't any change in that data over time. So bringing them in had no impact on inquiries, enrollments, or treatment. And I guess the challenge that we have there is trying to increase completion rates at follow-up, particularly for those clients who are no longer active in treatment. The other big challenge we found is that was 17 months of outcome measure data. To get that final sample of about 15,000 clients, we had over double the amount of data to deal with. So I guess this is the challenge of implementing one of these systems, is that you do need to have the processes in place to manage duplicates where clients complete the same survey several times accidentally, or clinicians send them the wrong survey. Sometimes there's data quality issues. And I guess, and people don't just come in once and stay, they come in and out. So which measure do you use as your 1 month and 3 month outcome if they're in and out a few times? And what are the clinical practices around that to try and make that more streamlined from a data quality and outcome measurement perspective? So big challenges there. But oops, what's happened here? I don't know why that's there. Sorry. I guess the reason that we do this is because we get to see some outcome measure data, and suddenly it's disappeared from here. So what we found was sorry, some of my slides are missing. I'm not sure what's happened. So on the A top, we found reductions in, I just wanted to show you some of the client outcomes so you can see why it's all worthwhile. So on the A top, we found reductions in alcohol, methamphetamine, and cannabis use in terms of the amount of the drugs that we're using, both in standard drinks and in grams on methamphetamine and cannabis. On the assist, we found the same thing. So we found that reductions in alcohol, methamphetamine, and cannabis in terms of the severity of their use and related problems over time. And they were pretty large reductions. I don't know why those slides are missing, sorry. For mental health, we found that for depression, reductions over time. So you can see there at service entry, when they came in, they were in the sort of the moderate to severe range, but within 1 month, they've fallen into that mild to moderate range and stayed down there at 3 months. And similar pattern for anxiety. So we found reductions from at service entry up around the average value being moderate to severe, and it drops down throughout treatment. So I guess that's sort of just showing you the value of measuring these outcomes, is that you can see data like this to see that treatment is really working as a service. But yeah, and I guess from this point, after we'd implemented this, the big challenges was how do we increase the uptake at follow-up so we can figure out who, what treatment works for who, and really get a sense of what's happening. And some of the other questions we had were, what happens if we implement these outcome measures before people enrolled in treatment? So put them at the front end of the service. What happens then? And then what happens if we start giving the clients automatic feedback when they complete the actual outcome measure? So in the previous model, the feedback was just going to the clinician to give to the clients. What happens if we give it to both of them, both the client and the staff member? And what if we add progress charts in so that people can see their progress over time graphically? And what if we give them normative feedback on how their alcohol and other drug use and mental health symptoms compare to the general population as well as other clinical populations? And what if we link, information to that feedback and to help give them the help that they need to try and make a change? And what if we did that all as part of a brief intervention, which was our next study? So we were lucky enough to have already have a brief intervention website called Quick Fix that we developed for another project. And the website, the web app already had the capacity to provide automatic feedback to both clinicians and clients and deliver those interactive progress charts. The good thing about the feedback is that it also contains links to a whole range of clinical resources that the client can access. So we thought if we can use that, we can further enhance the quality of the process, not only for the staff, but also for the clients. And maybe if we give automatic feedback to the clients immediately, maybe they'll be more interested in completing them at follow-up, which is the way we're heading. So this is basically just the process. So people complete the outcome measure in Qualtrics. It's then scored, and the feedback is generated by the Quick Fix web app. And then the feedback goes to both the client and the counsellor, with the idea being that then there's an interaction where the feedback is given to the client and discussed with them in the next session. So this brings us to the next phase, where we're in November 2021, where we put the baseline outcome measure at the front end of treatment at inquiry. Even before they met a clinician, we asked them to complete these outcome measures. Now, they were offered help with this if they needed it. But then the idea was that if they completed that measure, they could then get instant feedback for the staff. And then the other thing that Liza did was implemented a first step, which is brief intervention, which is an intervention that was co-designed with staff and clients. And what we did is we tested this phase in 4 outpatient services first, because we wanted to see what happened if we put these measures at the front end of the service and delivered the feedback as part of a brief intervention to clients. This is what the new feedback looks like. So you can see there that this is the comprehensive version that goes to staff. So staff receive feedback on the substances that the client used in the past 3 months, which you can see are listed there, as well as the frequency in which they're using it. The survey asks clients what their primary drug of concern is. So in this case, it was methamphetamine. They then receive normative data from the National Household Drug Survey on how their use compares to the general population. Clients can ask for feedback on 2 other drugs. So this person chose cannabis and tobacco. So they also received feedback on how their cannabis and tobacco use compared to the general population. This graph on the left is the the ATOP data that shows the total number of days the client has used the drugs in the past month. The next one down is the amount typically used in the past 4 weeks that they reported on the ATOP. And then that graph there is the severity of substance use using the assist cutoffs for moderate and high risk use. So you can see there that the clients definitely using methamphetamine in a risky way, as well as cannabis and tobacco, according to those cutoffs on the assist. We then also, you can see on that right side, the clinician has feedback there on methamphetamine use and the risk profiles and the frequency of some of the risky behaviours and consequences of that methamphetamine use that they can talk to the client about. And then there's feedback on mental health and which compares their depression, anxiety symptoms to normative data that we've collected at Lives Live Well, as well as whether the client was reporting suicidal thoughts, whether they reported a history of trauma and likely had a diagnosis of PTSD, as well as whether they reported having experience with psychosis and then chronic pain. It's worth noting that the client doesn't sort of receive the feedback on suicidal thoughts and trauma or some of the other information, and they get less feedback on the quality of life indicators. You can see that on the right, there's also some quality of life and general health things, including vocational functioning there. So lots of feedback. It's quite comprehensive. And these are the quality of life indicators from the ATOP. So the client feedback is the same as that, but they just get a lot less of the quality of life, and they don't get the suicidal ideation or trauma stuff. So Lives Live Well have extended this work, thanks to the work of Holly Stokes, to outcome measure suites for young people, First Nations people, DVA and perinatal, and we've got a student looking at measures for deafness. So lots of feedback. This is the progress chart. It's interactive. So the client can click on which drugs they want to have feedback on. So here they've got alcohol, cannabis, methamphetamines and sedatives. So this would be their baseline survey. This would be their 1 month survey and their 3 month survey. So they can see how it's tracking over time, as well as feedback on the typical quantity of use from the ATOP over time. The feedback that the client and staff receive have hyperlinks that take them to these fact sheets, which are arranged for 15 substances. We have fact sheets and harm minimisation tips, as well as a whole range of fact sheets on mental health, as well as other additional factors like homelessness that they access. In terms of the clients who ask for assistance, so remember we sent the outcome measures to the clients in this pilot before anyone even spoke to them. So around 93% completed it by themselves without any support, and around about 5 to 6% asked for support. So, and then we had about 2% complete the outcome measure via phone with the counsellor, and about 5% come in and do it face to face. So people did access that support when they needed it, but as you can see, it's pretty rare. This is just a map of what happened over time. The main points here are that when we put the outcome measures at the front end of the service, we had about 62% of the clients complete it. And that compares to about 69% in other outpatient services over that time frame. So we lose about 7%, but there's other benefits to it. And when we took the research out and saw what happened when it did drop a bit, but it's still pretty high. Pleasingly, when we put those outcome measures at the front end of the service, there was no real reduction in the number of clients who contacted the service who were eventually enrolled. That was a big concern of the services themselves, that clients wouldn't get in who wanted to wouldn't get in, and we saw that did not happen. But what we did see happen was a huge increase in the number of clients who enrolled, who got into treatment. So about 82% of clients who completed their outcome measure were enrolled, had at least one treatment session. And that was sustained after the research ended. And that compares to 35% in the other outpatient services. So something's happening there where if we ask them to complete the outcome measure before they come in, that more of those clients are getting into treatment or getting some treatment. And what we think it might be is that it's saving a lot of clinician time, trying to chase people to come in for assessments, missed appointments, things like that, because the people that are getting enrolled have already made that commitment by completing the outcome measure and coming in. So, but we're testing that properly at the moment. They're just hypotheses at the moment. So the key learnings there is that we've had from that pilot trial was that most clients will complete the outcome measures by themselves. It may be saving clinician time, reduce, and particularly staff time chasing people who are probably never going to come into treatment or enroll. And that when we did put outcome measures at the front end of the service, it didn't make people disengage from help seeking, because we found no reduction in the number of people who inquired, who are eventually enrolled. But what we saw was a large increase in the amount of treatment being received, which we thought was a positive. So now that work is complete, we were lucky enough to receive a National Health and Medical Research Centre for Research Excellence, where we're wanting to look at how do we increase the uptake and completion of outcome measures at follow-up. So at the moment, what we're doing is we're doing a large cluster RCT across 8 sets of services and lives of well, where we're looking at when we bring in this system where outcome measures are at the front end and clients receive this brief intervention with this feedback, does that improve outcomes, and does that do those things where I was talking about in the pilot, where there's no reduction in access to treatment, same amount of people are receiving treatment that were in the first place, but perhaps more of them to actually getting to a treatment session where they're receiving a brief intervention at the very front end of the service. And what we wanted to see is if we implement that automatic client feedback, which wasn't in the pilot, will that increase the uptake of outcome measures at follow-up? Lives Well are very brave, so they've expanded this to beyond the outpatient service that were in the pilot to their entire clinical program, to see the benefits of it, not only just in the outpatient programs, but in the residential programs, day programs, and withdrawal programs. And we're doing a whole range of research where we're trying to figure out what is the best scenario for delivering outcome measures to clients from both a client and staff perspective as part of that project. And the reason we want to do this and try and get all this outcome measure data is that we can use that data to improve the outcomes and cost effectiveness of treatment by developing these digital learning healthcare systems that tell us which clients respond to which treatments and how clients are tracking over time and how that compares to other clients with similar characteristics. So we can then try and, I guess, improve access to evidence-based and effective care. And that's kind of the work we've been doing together recently as part of the CRE. just wanted to acknowledge the huge team of people who've been involved in all of this research. It certainly wasn't done by myself, both from UQ, the National Centre for Youth Substance Use Research, and the Lives of Well team themselves. We wouldn't have been able to achieve this without working together. And we've had some vigorous discussions along the way to try and get things working. But I think, as you can see, it all pays off eventually. We can just get the systems working together. And finally, just really wanting to acknowledge all the people with lived experience who participate in our research, but also all of the clients at Lives of Well who've contributed to what we've done today. And thank you.
Oh, Leanne, thank you very much. And also just reinforce that acknowledgement you've made across the large teams. I know I've had some conversations with Nick up at Lives of Well as they've been rolling all this out and piloting everything. So it's awesome to see a little bit more of the picture and some of the earlier data that you've been collecting and the outcomes. And I have to say, as somebody who for many, many years did repeat ATOPs, I've never seen them presented so beautifully in terms of actually how they can and how they should be being used in terms of that kind of tracking over time. Look, we've had some questions come through, but for everybody out there who's with us, feel free to keep popping some things in the chat. We'll keep an eye on that, and we'll start off with some of these things that have come through to have a chat with you about. I noted there that you did some kind of, I don't know if you're going to be publishing on this, but some great research about validating tools in a kind of a, kind of different modality of using them online. So I don't know if that's coming out in anytime soon as part of this, but checking if they still have utility and everything. So that was great. So I just wouldn't mind asking, in terms of ethical considerations and just, riffing off a question that's come through here, were there any ethical considerations that had to be taken into account by moving this sort of front end and online?
Oh yeah, so we had a lot of discussions about and about what could possibly happen if we did this, and so we had a lot of checks and balances in place. So like I said, when we had, it was very clear that the client could reach out to us if they wanted assistance completing the measures. And Lives of Well have built a whole bunch of alerts into their system such that when someone comes in, if they report suicidal ideation or family violence, that they get alerts in their system so the clinicians can see that. We put a lot of work into, the emails that were sent with the outcome measures attached to make sure that people had access to other services if they needed more immediate support. So so it was a combination of making sure that clients had the information and support they needed in the emails and SMSs, but also the capacity of Lives of Well to respond to, because, the client could have done that measure at 1 a.m. in the morning and reported all sorts of things. So and so we had to have responses to that were automatically sent that made sure that they were given information about how to seek help, because it's not a 24-hour service. So there's a lot of thought put into that, and that's what I was talking about, all the policies and procedures and the work that was put into that.
Yeah, definitely, and very thorough thinking around all of that, and good to know for particularly if services are looking at implementing anything like this. I guess this might be some of the more sort of later phase research that you flagged, but just sort of, again, a question here around, was there work needed, I mean, other than the technicalities and the types of data and reporting, but that idea of helping clinicians, workers to integrate feedback into their practice, because that is a skill and a science as well. In terms of which I know is about improving the outcomes, which is and the service delivery. How that might have helped clinicians to identify ways to improve services, to tailor treatment and those sorts of things. Was there much work needed or to cover that?
Yeah, there was. We found when we did that initial implementation in November 2020 that, it was all part of a whole new system coming in. So it wasn't just outcome measures, it was a whole new relationship management system. So staff were really overwhelmed. So there wasn't much capacity there to train them much in giving feedback, which is why we made it a key focus of the next phase and made it part of a brief intervention where they were kind of provided with training in, how to give that feedback to a client in a really collaborative way that was consistent with motivation interviewing spirit and principles, and really use it as a conversation that would engage the client and help them think about what some of the issues might be and kind of move towards coming up with a plan for moving forward. So it's sort of it's a bit of a shortcut. So you've kind of got the information there, the client's already reported it, so you can kind of use that to engage them in a discussion around their substance use, as well as the other presenting problems in a motivation interviewing framework. So it kind of gives them that stuff to kind of jump into treatment straight away, that would have perhaps taken a couple of sessions to get to immediately. So they get that immediately. So the idea was that they come in and they're given treatment straight away, as fast as possible, because we know that people don't tend to stay around for more than 1 or 2 sessions as a norm. So it's sort of let's give them something as soon as they come in. So, and hopefully it's a positive experience. So even if they decide to not come back, they might be more interested in coming back because they found it kind of originally just instantly started addressing their needs.
Yeah, I was thinking that myself when you were presenting, that must that initial engagement it's shifted and changed a fair bit with the amount of information or kind of baseline data that a client comes in with. And any I don't want you to give anything away that might be up in lights later on in terms of some research and the good work that's going on there between yourselves and the partnership with Lives Live Well. Any kind of anecdotal feedback at the moment from the worker side of things, the clinician side of things, about how that is helping some of that kind of, I guess, focus of treatment early on, or other aspects?
Yeah, I think it's always a bit of a mixed bag, but I think it's with the new training coming in. I think they're finding it a positive experience, and they're seeing that some of the benefits of it. But again, there's always a group of people that want to do the get to know each other assessment, take it slow type thing, and I guess and that has been a bit of a challenge, but I think we've had some wins with them as well, because it's not that they can't do that, it's just we want them to do this initially and then move into that. So I think it was just making it really clear that treatment process can happen, but we just want to make sure that people that are coming into treatment are getting treatment straight away. That they can do their assessments and things later, kind of thing. I hope that makes sense, but yeah.
No, it kind of does, because I imagine that was one of the things that people, understandably, a lot of clinicians are concerned about rushing at people with a big pile of paperwork, even if it's...
we're very careful that it wasn't death by feedback, so it's like, be a bit selective about what you're giving them feedback on. You don't need to read every bit, they can walk away with it, that kind of thing. So yeah, it's a balance, but it's also I mean, my background's in clinical psychology, and we were trying to engage people and then do an assessment and then a formulation, and so it is different to people's training. But when we spoke to clients, they don't want to tell their story again. They've told it unless it's their very first appointment. They've told their story so many times.
That's very consistent with trauma-informed approaches as well, and those things. So yeah, that's a really good kind of nugget to take out of this as well. Just a question that's popped in here about any feedback from clients that they find this method as more user-friendly, especially in this current world where having a mobile phone and app is the norm.
Yeah, we've done a whole range of interviews with clients to get ready for this next trial. Unfortunately, in the previous trial, we weren't sending them feedback straight away because we wanted to just do one step at a time. So it went to staff originally. So often clients didn't receive the feedback. But then when we did interviews with them, just because they didn't come in or something happened, when we did interviews with them and showed them the feedback, they loved it. They're like, this would have been really useful. We wish we'd seen it, yes, send it to us immediately when we do this. And that's what's informed the next part of the trial. So yeah, I think they like it. Not everyone loved it though. We asked them when you'd want to receive the feedback, and we'd assume they'd want it immediately, but probably less than 5% don't want it immediately. So we've built in an option so they can either say, I don't want to see it. I would rather talk about it with my clinician, or they can say they can give it up to a 7-day delay in receiving it, because they might just not be in the headspace to receive it after doing the survey. So we built that flexibility in response to that. But yeah, vast majority want to see it straight away.
Yeah, sure. And just Leanne, if you've got time, and for those online, we're doing well with time. So just a question that's come through here. What strategies can be used to manage the potential of bias that comes from primarily receiving follow-up completions from engaged clients who may have better outcomes versus clients who disengaged and may have poorer outcomes? Yeah, that's always that difficulty, isn't it? It's like the non-completers, or the people who didn't engage, what's going on?
Yeah, it's a great question. We do have other research where we chase people for follow-ups, and we get follow-up rates of about 80% when we're doing a proper trial. But I guess in the real world, there won't be an army of, we don't really cover an army, but a bunch of RAs to chase people to try and ask them to complete these. Plus we reimburse them for the time, so they get $20. So so that's the real challenge of what we're trying to do, is how do we engage the clients in completing them themselves by showing them the potential benefits to themselves. And it's that kind of balancing act. And that's one of the projects we're doing at the moment, is trying to see under what scenario would a client be more likely to complete them or not. But there will always be that bias that the people that are the least active in treatment are probably the least likely to complete the measures, and that will always be a problem. And there's really not much we can do about that in the real world. It's just apart from just trying our very best to engage them in the process by showing the benefits of that overall.
Great. And the person who asked the question says thanks for that. Yeah, and it's the real world of things. We always want to set out to find out that stuff. It's a little bit harder in practicality.
I mean, we could just do really brief things like if they don't want to do the whole survey, get them to answer a question about how they're doing, and something like that. People would most people would be happy to answer one question. The big challenge is just all the all of the scams that are out there, and trying to not be caught up, not people thinking that you're a telemarketer when you're calling them, or you're trying to scan them online. I think that's one of the big challenges we're going to face moving forward.
True. Based on that, I guess that was one of those, surprises or things identified once you kind of went live with all this. Were there any other kind of unintended things or surprises that you came across?
I was just surprised by how willing the clients were to complete them in the first place. Like I said, I would have been happy if half of them have done it, but from day one, around 60 to 70% have been completing them. So I think that's remarkable. But when you think about it, it makes sense, because it's a help-seeking attempt is when they're asked to do it. And then if they were asked to do it in enrollment or before they came in, it didn't seem to matter in terms of the proportion of clients who would complete it. So I think it's a really positive thing that 70% of people seeking help are willing to do that. And that's the thing. And the challenge is getting them to complete them whenever follow-up is. But to me, that's a really positive sign of engagement and hope with the help attempt that I think we really need to capitalize on and give them credit for. And I think the most important thing to do is make sure we acknowledge that and give them feedback on it, because I've gone with effort.
Yes, absolutely. Praising the effort and the time involved. Look, no, that's great. I'm just checking our list here. I think that's all the questions that we kind of had come through. I suppose I'll just hand over to you, Leanne, in terms of anything else that you think is important that has come to mind. If not, that's all good. It's been very comprehensive, and the slides that Leanne's kindly and generously shared. And here we go. Sorry, there's just a comment that's come through here. Is it possible to hand out a brief leaflet to the consumer on admission or discharge in hospital? I think that probably would be more about the programs of Lives Live Well, wouldn't it?
What was the beginning of is it possible to do what? Sorry?
Possible to hand out brief leaflet to the consumer on admission or discharge in hospital. Yeah, not quite sure. Sorry, apologies to the questioner there. If it's about information about the Lives Live Well services and the types of things that are offered in the treatment, that would be going to liveslivewell.org.au. They have some really good information on their site.
We have been talking to some people in Queensland Health about trying to do a similar thing in some of their short stay mental health units and trying to address substance use there. So we are trying to see if it's possible to deliver some feedback to clients in that context. So it is something we're trying to do, but it's a bit challenging with the health systems themselves, as you can imagine.
Things get there. They
yeah.
move slowly sometimes.